Hi there. My name is Dr. Casey Means, and I am thrilled to be speaking to this group today about continuous glucose monitoring in a general wellness population. I am a medical doctor focusing on functional medicine and a systems and network biology approach to health, and am the co-founder and chief medical officer of metabolic health company Levels, which leverages continuous glucose monitors and intelligent software to help individuals optimize their diet and lifestyle. Here are disclaimers and copyright information. Our learning objectives for today are to first understand how continuous glucose monitors work and their current indications. Second, to understand the emerging trend of CGM use in non-diabetic populations for wellness purposes. Third, to understand the value of continuous glucose data compared to other testing methods. Fourth, to learn how glucose control contributes to brain health and mental health, including anxiety, depression, dementia, and cognitive decline. We'll also explore how glucose control relates to longevity, and lastly, how CGM can help personalize diet. So what is a CGM? A continuous glucose monitor is a prescription device for monitoring blood glucose from interstitial fluid, or the fluid around cells. These glucose values are automatically taken by the continuous glucose monitor at 5 to 15-minute intervals, depending on the device being used. And the information is sent to a smartphone or an external reader for interpretation. In individuals with type 1 diabetes, these devices, these continuous glucose monitors, may also connect to an insulin pump for a closed loop system of CGM and insulin delivery. There are 4 main manufacturers on the market for CGMs, including Abbott, Dexcom, Medtronic, and Senseonics. The Abbott Freestyle Libre is worn for 14 days and is indicated for the management of diabetes, type 1 or type 2, in persons age 18 or older. The Dexcom G6 is worn for 10 days and is indicated for the management of diabetes in persons aged 2 or older. The Medtronic Guardian Connect is worn for 7 days and is indicated in patients ages 14 to 75 with diabetes, type 1 or type 2. And these devices are designed to replace blood glucose testing for diabetes treatment decisions. Currently, approximately 38% of individuals with type 1 diabetes are using continuous glucose monitors as of 2018, and that's compared to just 6% using them 10 years ago. So how does the CGM work? The CGM is made up of a plastic disc device that is adhered to the skin, either on the abdomen or the back of the upper arm. From that plastic disc is a flexible, thin metal filament that it differs in length between the different sensors, but in most of them, they're approximately 5 millimeters in length and about 0.4 millimeters wide. So very, very thin microfilament. And this sits underneath the skin in the interstitial fluid. The filament is what is measuring the glucose, and it's coated with an enzyme called glucose oxidase, which converts glucose to hydrogen peroxide, which then generates a current, which is sent wirelessly to a smartphone or a reader to be registered as a glucose reading. And just to note, there is typically about a 5 to 10-minute lag between blood glucose levels in the blood and blood glucose levels in the interstitial fluid as that glucose seeps out of the vessels into the interstitial fluid. There has been an emerging trend for individuals without diabetes to use continuous glucose monitoring technology for purposes outside its initial indication, which is, as I mentioned, for the management of type 1 and type 2 diabetes. So there's companies like my own company, Levels, and others like Super Sapiens, Nutrisense, Veri, and others that are making CGMs available to a broader general wellness population, along with an interpretive software layer to really transform this data stream and make it useful for personalized biofeedback for diet and lifestyle choices. These companies are using a system where they're having independent physician networks evaluate customers for prescriptions for CGM devices. And then the purpose of the software used with the CGM is to help with this personalized dietary and lifestyle biofeedback, not for the diagnosis, treatment, or management of any specific disease. And the aim of these technologies is really to demonstrate trends, such as food choices that lead to a glucose spike or ingredients that lead to a glucose spike. So users can really learn to eat and choose lifestyle activities that generate a more stable glucose level. Initial customers of this type of technology are people like biohackers, longevity advocates, longevity seekers, fitness and nutrition enthusiasts, professional athletes. But the longer term goal is to expand this to a broader general wellness audience and into the prevention space. So moving it out of the realm of just for treatment decisions for diseases that have manifested and more into that prevention and general wellness space. The motivation for use in the general population stems from the rising epidemic level of metabolic dysfunction in US adults. Currently, 88 million Americans have prediabetes, and of those, more than 84% don't know that they have it. The rates of diabetes are also increasing, with 13% of the US population or the US adults having type 2 diabetes, and more than 20% of adults with diabetes unaware that they have it. As we know, type 2 diabetes is largely preventable, and it's suggested that upwards of 9 in 10 cases of type 2 diabetes are preventable. In a recent study from UNC, their data in 8,700 people showed that 88% of the population studied had at least one biomarker of metabolic dysfunction. So almost 9 in 10 American adults with at least one biomarker of metabolic dysfunction, not necessarily prediabetes or diabetes, but some marker showing metabolic problems. In this study, metabolic health was defined as having optimal levels of waist circumference, glucose, blood pressure, triglycerides, and HDL cholesterol. And these people could not be taking any medications to be considered optimally metabolically healthy. So if all 5 of those factors were in the normal and healthy range, a person was considered metabolically healthy. And that only applied to 12% of the 8,700 people studied, which is fairly incredible. So a question you might be asking is, why use CGM over fasting plasma glucose or hemoglobin A1C or oral glucose tolerance tests are 3 standard metrics of assessing metabolic health? And why use CGM over these for tracking progression towards metabolic dysfunction? The main reason is that fasting glucose and oral glucose tolerance tests capture only one or a short series of time points. It's essentially looking at a snapshot in time. A1C gives a longer lens, looking at approximately the 3-month average of glucose levels, but none of these assess glycemic variability, meaning the amount of sort of ups and downs in glucose levels during the day and over time, which is correlated with metabolic dysfunction. We know that increasing glycemic variability, those ups and down swings in glucose, is a biomarker of increasing insulin resistance and more complications in people with diabetes. Continuous glucose monitoring, unlike these sort of single or short time series measurements, is like a continuous movie of glucose levels and tells us about glycemic variability with very granular detail on a many day basis for the first time. And again, going back to just sort of the science of glycemic variability, these large glucose swings, big ups, big downs, have been shown to potentially be more harmful than sustained high glucose levels alone. And they're very much an important health marker that we haven't been able to track before the advent of CGM monitoring. It's thought that these excessive peaks and dips in glucose can lead to tissue damaging metabolic byproducts such as free radicals, endothelial dysfunction, damage to nerves, chronic inflammation, and activation of the sympathetic nervous system. And as a person becomes more insulin resistant and moves down that spectrum of metabolic dysfunction, they will tend to show more glycemic variability, both just at fasting and also post meal. And so CGM can be a really helpful tool for both tracking glycemic variability and also learning how to reduce it by making sort of personalized choices about diet and lifestyle that keep our glucose levels and our glycemic variability lower. So next, I'd like to shift gears to our learning objective about the relationship between glucose control and anxiety. It has been shown that people with diabetes have about a 20% higher higher prevalence of lifetime diagnosis of anxiety than those without diabetes. So people with diagnosed metabolic disorders have higher risk of developing anxiety. In people with diabetes, an acute hyperglycemic episode can also lead immediately to symptoms of sadness and anxiety. This same experiment found cognitive impairment during that hyperglycemia episode as well. In another study, diets higher in glycemic index were associated with increased odds of depression and anxiety, with those in the highest tertile of glycemic index having an odds ratio of 1.44 and 1.52 for depression and anxiety, respectively. Lastly, A case report of a woman with generalized anxiety disorder showed that shifting the diet from a diet of primarily refined carbohydrates to a diet of increased protein, vegetables, healthy fats, fiber, seeds, beans, and fruits, essentially a lower glycemic load diet, decreased generalized anxiety symptoms in 2 days. And in this study, the woman actually reverted to the original diet and had a return of anxiety symptoms in just 1 day. The mechanisms that increase anxiety in the context of metabolic dysfunction may be linked to insulin resistance. In one mouse study, when researchers removed insulin receptors via targeted knockout from the brains of mice, they found that it triggered anxiety behaviors. A recent study demonstrated also that knockdown of insulin receptors in astrocytes also generated anxiety and depressive-like behavior in mice via decreased purinergic signaling and altered dopamine release. There may also be a relationship between microbiome and anxiety behaviors. Diet-induced obese mice showed symptoms of depression and anxiety and reduced insulin signaling in the brain's emotional regulation centers, including the nucleus accumbens and amygdala. When these mice were treated with antibiotics, when these mice with dysbiosis were treated with antibiotics, it actually reduced their anxiety and depression and improved blood sugar levels. When the microbiome of the obese, anxious mice was transferred to germ-free mice, it actually caused the germ-free mice to develop the same anxiety symptoms as the original mice. On the flip side, we may be able to reduce anxiety by improving glycemic control. A study on a regular practice of coherent breathing in people with type 2 diabetes and ischemic heart disease saw participants increase their heart rate variability and significantly lower their hemoglobin A1C after 3 months of consistent practice. Following other studies that show stress management can help diabetes control, the authors of this study suggested that breath work decreased the activity of the sympathetic nervous system, which helped improve glucose levels. A study in healthy college-age participants looked at the short-term effects of a couple of minutes of relaxed breathing, and this breathing was involving extending the length of the exhale. And they looked at how that was impacted glucose processing. Researchers had the students repeat this just short period of relaxed breath work every 10 minutes for 30 minutes before an oral glucose tolerance test and for 90 minutes after. The study found that the breath work blunted the glucose response significantly at 30 minutes after ingestion of the 75 grams of glucose. And in the study of in the group with controlled breathing, so not having the relaxed breathing intervention, the 30-minute peak was 173 milligrams per deciliter. And for the people who did the relaxation breathing, it was 136. So quite a big delta. Moving on to depression, a large study of nearly 70,000 women between the ages of 50 and 79 showed that diets high in added sugars and with a high glycemic impact increase the odds of depression. As the dietary glycemic index increased, so did the odds of depression. A meta-analysis found that depression risk is 1.33 times higher in people with diabetes, and perhaps as many as 9.5 million of global depression cases are potentially attributed to diabetes. A meta-analysis of dietary patterns and depression in community-dwelling adults showed reduced risk of depression among adults who had a healthful dietary pattern that included high intake of fruits, vegetables, whole grains, poultry, fish, and reduced fat dairy products. The results suggested that high intake of these foods may be associated with a reduced depression risk with an odds ratio of 0.84 compared to a standard Western diet of refined and processed foods. The mechanisms relating to poor glucose-controlled depression are likely multifactorial. And here are a few examples of potential mechanisms. First, it's thought that insulin resistance in the brain may lead to depressive symptoms. In studies of knockdown in mice who've had a knockout of insulin receptors in the brain, the mice tend to get depressed and anxious, as mentioned previously in the slides on anxiety. As insulin resistance develops, it may have similar negative effects on the brain as what we're seeing in these insulin knockout mice and contribute to mood issues. Second, there may be decrease in brain cell growth with high blood sugar. Third, neurogenesis appears to be impaired by diabetes. This may be due to mitochondrial dysfunction when insulin resistance has developed. In mice, therapies that increase insulin sensitivity appear to increase mitochondria, reduce depressive symptoms, and increase brain cell neurogenesis. Additionally, impaired neurogenesis is seen in insulin-resistant states, and research suggests that insulin resistance in the brain alters the signaling pathway that allow for optimal wiring of brain cells related to reward and learning behaviors, and that the impairment in wiring is linked to depressive symptoms and reduced ability to adapt to stress. Fourth, insulin stimulates chronic stress hormones, and insulin resistance in the brain can impair that negative feedback on the brain's stress hormone pathway. This creates a vicious cycle between insulin dysfunction and increased stress, and insulin resistance may actually contribute to depression through an abnormal stress response in the brain. Lastly, an increase in inflammation that affects the brain also reduces serotonin activity. It's thought that TNF alpha, a pro-inflammatory cytokine elevated in patients with diabetes, decreases the level of serotonin in the brain. And as we know, serotonin is a neurotransmitter implicated in depression. Continuing to talk about the glucose brain health connection, and now moving on to the relationship between dementia, Alzheimer's disease, and glucose control. There was a study, a recent cross-sectional study looking at 500,000 adults from the UK, ages 40 to 69, and compared hemoglobin A1C levels with incidence of vascular dementia, Alzheimer's dementia, and cognitive decline. It found that people with prediabetes had a 1.5 times higher risk of vascular dementia than people with a normal hemoglobin A1C. And people with known diabetes were 3 times more likely to develop vascular dementia. Prediabetes and undiagnosed diabetes suggested around a 40% higher risk of cognitive decline. Another study in Korea showed people with metabolic syndrome were 11 times more likely to develop Alzheimer's dementia. And a 2019 meta-analysis of 144 studies found diabetes increased the risk of cognitive dysfunction, and prediabetes is also a risk factor for all forms of dementia. In this study, diabetes conferred a 1.25 to 1.91 fold excess risk for cognitive disorders, including cognitive impairment and dementia. The mechanisms for cognitive decline in the setting of poor glucose control are also likely multifactorial. First, amyloid deposits seen in Alzheimer's dementia trigger an immune response from the body, and the resulting inflammatory response can cause neurodegeneration. And we know that metabolic syndrome and insulin resistance causes additional chronic inflammation, which can exacerbate and sort of synergistically promote Alzheimer's progression. Metabolic syndrome is also associated with oxidative stress, which can lead to vascular dysfunction and damage due to the damage to the blood-brain barrier. This process also impairs the ability to clear plaque deposits. Lastly, there are insulin receptors throughout the brain, including areas related to memory, like the hippocampus. And so insulin resistance, which impairs those cells' ability to use insulin properly, can contribute to Alzheimer's dementia. As insulin is an anabolic pro-growth signal, its effects are not just limited to regulating glucose, as in some other cells. It also can contribute to neural development and neurogenesis, including learning and memory. And so insulin resistance and the blocking of this signal can lead to damage and reduced neurogenesis in the brain. Insulin resistance also leads to mitochondrial dysfunction in the brain and impaired bioenergetics. Epidemiologic research shows that a standard American diet high in processed foods and carbohydrates and added sugars has been associated with reduced brain-derived neurotrophic factor, BDNF, in the hippocampus, as well as smaller hippocampal volume. Moving on to our second to last learning objective, I'd like to touch on the relationship between glucose and longevity. Hyperglycemia, insulin resistance, and hyperinsulinemia are related to accelerated aging and reduced longevity by several mechanisms, including the formation of advanced glycation end products, the production of oxidative stress and production of free radicals, mitochondrial dysfunction, inflammation, changes in transcriptional pathways, and endothelial dysfunction. First, we'll talk about advanced glycation end products, AGEs. Glycation is the process of a sugar molecule getting stuck to proteins, fat, and DNA in the body. Glycation alters the shape and conformation of proteins when sugar sticks to those proteins, which can lead to dysfunction in the action of the protein, as well as protein aggregation and cross-linking. The glycation reaction, also called the Maillard reaction, creates what is called an advanced glycation end product, which then binds to the receptors of these AGEs, which are called RAGEs, which then leads to the generation of reactive oxygen species and inflammation. An example of this happening is actually wrinkling of the skin, where collagen fibers are glycated, and this leads to abnormal cross-linking of these collagen fibers and accelerated aging and wrinkling of the skin. Second, we'll talk about free radicals. So hyperglycemia is implicated in the generation of excess free radicals, which is known as oxidative stress via multiple pathways. And this has strong links to many diseases of aging, including diabetes, cancer, kidney disease, COPD, chronic obstructive pulmonary disorder, and cardiovascular diseases. Free radicals are byproducts of metabolism and are reactive molecules that have an unpaired electron that can cause damage in the cell when it tries to neutralize itself by binding to other parts of the cell. You have probably heard of antioxidants in food, which are some substances that can neutralize a free radical so that it causes less damage. We can also make our own endogenous antioxidants through expression of specific genetic pathways. It's thought that many of the vascular and multi-organ complications seen in diabetes are caused directly by hyperglycemia-induced overproduction of reactive oxygen species, which is a type of free radical. Even brief episodes of hyperglycemia can cause tissue damage by mechanisms involving repeated acute changes in cellular metabolism. And exposure to high glucose also causes cumulative changes in long-lived macromolecules, which persist despite restoration of normal glucose levels. The third mechanism I want to talk about is mitochondrial dysfunction. Mitochondria play a key role in metabolic processes in all cells, namely in their ATP generating capabilities via the electron transport chain. Unsurprisingly, interference and hampering of mitochondrial function is a hallmark of many pathologic conditions and a central event of the progression of many diseases, as cells can't generate energy effectively or produce excess damaging metabolic byproducts. The processes through which mitochondrial dysfunction causes pathology is typically through generation of inflammation, oxidative stress, cell death, and loss of tissue function. So many similar players as we've talked about. When there is mitochondrial dysfunction, there is impairment in metabolic fuel oxidation, and this can lead to accumulation of toxic lipid metabolites. Specifically, a decrease in fatty acid oxidation due to mitochondrial dysfunction induces the buildup of byproducts called ceramide and diacylglycerol, also called DAG, which have been shown to essentially gum up the inside of the cell and impair the insulin signaling transduction pathway. An increase in electron donors derived from nutrient oversupply and chronic overnutrition. So essentially eating too much substrate for the mitochondria. This can increase electron supply to the mitochondrial electron transport chain, which in turn induces a high proton gradient across the inner mitochondrial membrane, which, if not coupled to an increase in ATP synthesis, culminates in greater reactive oxygen species production, which further damages the cell. So you can imagine that if the body is just constantly getting the signal of too much food, too much nutrition, this has to be processed by the cells, and that can create excess electron donors, which, if not coupled with this increase in ATP synthesis need, can sort of lead to this excess byproducts like reactive oxygen species. Aside from nutrient oversupply causing damage to the mitochondria, many environmental toxins like cigarette smoke and pollution, as well as sleep deprivation, can cause mitochondrial dysfunction. Exercise improves mitochondrial health, and you can sort of see why, because exercise generates a stimulus for ATP production that will then allow the cell to work through some of that nutrient oversupply and therefore may balance the electrochemical activity of the mitochondria and minimize reactive oxygen species generation. So next is a big one, which is inflammation. Studies in human obesity and insulin resistance have revealed a clear association between the chronic activation of pro-inflammatory signaling pathways and decreased insulin sensitivity, with elevated levels of TNF alpha, interleukin 6, and interleukin 8 all having been reported in various diabetic and insulin-resistant states. In addition, the inflammatory biomarker C-reactive protein, a non-specific acute phase reactant, is commonly elevated in human insulin-resistant states. In human studies, it's been found that after an overnight fast, if you look at this study, looked at 10 young, lean, healthy subjects. If you're fed 3 meals providing 50 grams of carbohydrates, these individuals will have an immediate increase in the expression of NF-kappa B, which is one of our master inflammatory genes. So essentially, high carbohydrate load acutely increases the upregulation of pro-inflammatory genes. Additionally, high glycemic diets seem to promote death from inflammatory diseases. In one study, it showed that over a 13-year period, women in the highest glycemic index tertile for diet had a 2.9-fold increase in risk of inflammatory death compared with women in the lowest GI tertile, glycemic index tertile. Increasing intakes of foods high in refined sugar or refined starches and decreasing intake of fiber and non-starchy vegetables also independently predicted a greater risk. Hyperglycemia and hyperinsulinemia, high insulin levels, also changes gene expression, with low glucose levels activating longevity genes. Specifically, low glucose provides the benefit of activating hTERT. hTERT stands for human telomerase reverse transcriptase, an enzyme that keeps telomeres from shortening when cells divide. When food is scarce and glucose is low, FOXO activates longevity genes, which help the organism make it through lean times until food is available. Glucose restriction may also slow age-related mitochondrial deterioration by activating SIRT3, a member of the sirtuin family of genes known to protect against age-related disease and activate new mitochondria. So overall, it appears that glucose restriction has a positive effect on activating longevity genes. In addition to the hyperglycemia and hyperlipidemia-induced toxicity, insulin resistance and hypertension directly promote damage at the level of the blood vessel walls, which are manifested through the development of endothelial dysfunction. The term endothelial dysfunction refers to maladaptive blood vessel lining, where the cells are generating less nitric oxide, a key vasodilator, and where there is increased oxidative stress and expression of pro-inflammatory and prothrombotic factors, all of which precedes the early development of micro and macrovascular diseases and complications. And it appears that insulin resistance and hyperglycemia directly contribute to this endothelial dysfunction, which leads to many of the end organ damage that we see in metabolically dysfunctional states. Moving on from mechanisms linking hyperglycemia to decreased longevity, here's a look at what the epidemiologic evidence says. First of all, diabetes is associated with 8 of the 10 leading causes of death in the US. Anything here that has the arrow means that there is research to show that dysregulated blood sugar contributes to this outcome. So when you look at heart disease, cancer, stroke, Alzheimer's disease, which is now being called type 3 diabetes, influenza and pneumonia, nephritis, and intentional self-harm, including suicide, all of these have evidence showing that impaired glucose regulation or high glucose levels either directly causes or worsens the morbidity of these conditions. On the right, you can see that diabetes is associated with premature death from many different conditions, including cardiovascular diseases like coronary heart disease, stroke, and heart failure, several cancers, including liver, colorectal, lung, breast, and many other diseases like chronic obstructive pulmonary disease and liver and kidney disease. In addition, the cause-specific cumulative mortality for cardiovascular disease, cancer, and non-cardiovascular, non-cancer causes was significantly higher in individuals with diabetes compared to the general population. Bottom line here in this slide is that high blood sugar contributes to premature death from a variety of causes. Great. So now we've talked through how glucose control relates to mental health and brain health, as well as how hyperglycemia and metabolic dysfunction is related to longevity. Lastly, I'd like to touch on how continuous glucose monitoring can help us personalize diet. A premise that is important to realize is that glucose responses to food show high individuality, which somewhat contradicts the concept of the glycemic index. So that's the sort of standardized value assigned to foods based on how slowly or how quickly those foods cause increase in blood glucose levels. From the standpoint of the glycemic index, we would expect an individual food to have the same impact on glucose amongst large populations of people. But what has been found in more recent research is that the responses to the same food can vary widely across different people. A paper published in 2015 in the journal Cell called Personalized Nutrition by Prediction of Glycemic Responses, done out of the Weizmann Institute in Israel, looked at 800 non-diabetic individuals wearing CGM and demonstrated that the responses to standardized meals varied widely. In addition, as seen in the image on the right here, two people could eat the same two foods, such as an identical cookie and banana, and have actually equal and opposite responses to those two foods. So person A could have a large spike to a banana and virtually no spike to a cookie. And person B could have a large spike to a cookie and virtually no response to a banana. In this study, they looked at several biomarkers that predicted how people would respond to these different types of foods in terms of glycemic response. And one of the key factors was actually microbiome composition. Another premise that is really important to note is that in addition to diet, lifestyle factors like sleep, stress level, and exercise can also acutely impact glucose levels and insulin sensitivity. The beauty of a continuous glucose monitor is that an individual can see the acute response of their own body to different factors like food choices, sleep loss, stress, or exercise, and also learn how to minimize our glucose response by individually tailoring diet and lifestyle choices. And this is out of the scope of this talk, but it's definitely worth looking into the research on sleep deprivation and physical activity on glucose control. In one very interesting study that looked at 6 young, healthy volunteers that were subjected to several nights of low sleep, essentially 4 hours a night for sleep. After that intervention of several nights of low sleep, these individuals who were young and otherwise healthy, non-diabetic, were given an oral glucose tolerance test. And what this showed is that these individuals had developed impaired glucose levels just because of that intervention of sleep deprivation. So even a few nights of poor sleep can have a significant impact on our glucose tolerance and insulin sensitivity. So how can CGM help personalized diet? Digging into this even more, it's likely that our standardized ranges for categorizing people as either normal, pre-diabetic, or diabetic may not be sufficiently stringent for adequate risk stratification. And CGM can help give us a little bit more granularity into that. So studies show that individuals at the high end of the normal range for fasting glucose actually have increased risk of disease. So it's not like if you're under 100 milligrams per deciliter for fasting glucose, you're exactly the same as someone who's 70 milligrams per deciliter fasting glucose. There's actually quite a bit of increase in risk as you move from a low normal fasting glucose to a high normal fasting glucose, which is different than what people often hear in the doctor's office, where they're their lab tests show that their fasting glucose is anywhere under 100, and they're told you're normal, you're good to go, you're not pre-diabetic. So research in children has shown that having a fasting glucose measurement of 86 to 99 milligrams per deciliter, while still in the normal range, increases the risk of developing prediabetes and type 2 diabetes by more than twofold compared with children who have a fasting glucose less than 86 milligrams per deciliter. A large study here, and there's a figure shown, and this was in the New England Journal of Medicine, showed that in adults, as fasting glucose increased from under 81 milligrams per deciliter up to 99 milligrams per deciliter, there is an increased risk of developing diabetes by as much as 3 times. And despite these people all meeting the criteria for quote unquote normal fasting glucose by ADA criteria. So given this data, there is likely rationale for, really allowing individuals to have more visibility to their day-to-day fasting glucose levels and trends over time, to have more agency and awareness over what is happening. Based on this data, in my own practice, I typically recommend that people keep their fasting glucose levels ideally between about 70 and 85, as opposed to the standard criteria, which is just keep it under 100, and that's fine. There's also research suggesting these two studies that I mentioned have to do with increased risk of type 2 diabetes as fasting glucose increases from low normal to high normal. But similar research exists for cardiovascular disease and stroke, the risk of which both go up as you move higher in terms of fasting plasma glucose in the normal range. Given that, that was talking a bit about fasting glucose, but also given that postprandial hyperglycemia is also a significant risk factor for type 2 diabetes and other chronic conditions, we can now sort of posit that having more visibility into these trends and how to control postprandial hyperglycemia could really emerge as a high-value wellness and prevention tactic. If we can have better insight day to day on what's happening with our postprandial glucose levels, we can potentially learn to adjust our dietary choices or incorporate more lifestyle techniques to keep those postprandial peaks lower. With this said, more research needs to be done to understand whether a healthy non-diabetic person keeping their postprandial peaks over time lower does lead to differential clinical outcomes, and whether CGM use over time can help people improve their postprandial glucose levels. Lastly, one of the key powers of CGM is that it can help you understand your level of glycemic variability. And again, this is a biomarker of worsening metabolic health and insulin resistance. And it's not something that's visible with standard diagnostic tests of fasting glucose, oral glucose tolerance tests, or hemoglobin A1C. I love this figure on the right, where you can actually see 3 different levels of glycemic variability. Someone who has really high glycemic variability, person A, sort of medium glycemic variability, person B, and someone who's pretty stable, but then has like a really large peak and that stays elevated for a while, which is person C. All of these people actually have the exact same mean glucose levels. So what might be picked up on a hemoglobin A1C. And yet person A, who's going up and down with really high amplitude glucose spikes, is likely going to have much, much worse metabolic outcomes than person B, who's in a much more tighter range around that mean. And so that's information that we have just not been able to see based on the standard tests that we've been looking at today, certainly not from a fasting glucose level or a hemoglobin A1C test, which just shows the average. Continuous glucose monitoring allows individuals to monitor their reactions to specific foods, specific ingredients, and lifestyle choices in near real time. So for anyone who hasn't used a CGM on their self, you can essentially have a meal, you eat your breakfast, for instance, and within 10 minutes may start seeing a change in your glucose levels, and then monitor that glucose change over the course of the subsequent 2 to 3 hours. What many companies like my own company, Levels, are doing is adding an interpretive software layer to allow users to really synthesize that data stream to glean actionable information. So if you have a salad with 10 ingredients and your glucose goes up quite a bit after that salad, how can you start to learn which specific ingredients are likely the drivers of that response? The software can also integrate other data streams like activity data, sleep data, step data, potentially in the future, heart rate variability data, which could tell us an objective measure of stress. Merge those with the continuous glucose data stream and create those higher level insights, helping people understand what aspects of their lifestyle are supporting their glucose levels and glucose stability, or which are contributing to more glycemic variability. And in addition, the software can create community and sharing of learning and insights amongst individuals who are striving for optimal health and wellness. Recent research showed in 2018 that 80% of consumers find conflicting information about food and nutrition, and 59% of people say that this makes them doubt their nutrition choices. There's clearly very widespread misunderstanding about nutrition. About 60% of our calories in the US are from ultra processed foods. And we really don't have a good sense of how food is affecting our bodies. It's very much an open loop feedback system right now with nutrition, where we make interventions, we try things, but we don't actually get that closed loop on whether it's helping us or hurting us for a very long period of time. It might be that 6 months down the road, you get a cholesterol test or a fasting glucose test, and it may be slightly different than last year, but that's not necessarily helping you shape your day-to-day choices or helping you stay accountable to choices that you're making. So CGM can provide significantly more objective data for making these decisions. So what does the future of glucose monitoring look like in a general wellness population? Well, for CGM to become more widely used by individuals and doctors for this indication of wellness purposes and prevention, so less of disease management and treatment, but more wellness purposes and prevention, what's really needed is more validation studies. There will definitely need to be more research to show what the target 24-hour glucose ranges are in non-diabetic people to help guide people towards sort of what to strive for and what is associated with optimal health. Right now, all we've really got is the ADA criteria, which says that we want a fasting glucose below 100. And we've got data from the International Diabetes Federation that says that we should keep our post-meal levels under 140 milligrams per deciliter. But while that's a start, it doesn't necessarily tell us like what, for someone who's striving for longevity, for optimal mental health, for optimal metabolic health, what should we really be striving for in terms of our average glucose levels, our post-meal spike peaks, how soon we should come back to baseline. So a lot more research needs to be done linking clinical outcomes with continuous glucose monitoring trends in a non-diabetic population. There are several studies that have been done where continuous glucose monitors have just been put on healthy people and observed for glucose trends. However, these studies have not yet looked at clinical outcomes associated with those glucose values. So these are much more observational studies, and they do provide some really interesting information. So in these studies, mean average glucose is typically around 98 to 105, depending on what study you're looking at. And in these studies, these healthy non-diabetic individuals wearing continuous glucose monitors stay between glucose levels of about 70 and 140 milligrams per deciliter for nearly all the time. So well over 90% of the 24-hour periods, basically suggesting that for a healthy non-diabetic individual, glucose really should stay between 70 and 140 pretty much 24 hours a day. In some of these studies, especially in younger populations, that the data shows that people stay between 70 to 120, so a tighter range over 90% of the day. So that's kind of general gestalt based on that data of where a typical non-diabetic person may live in terms of their glucose levels. And if we do see an excursion after a meal to 150, 160, 170, 180, that's really out of the norm. It's not something that we want necessarily. And that's supported by the International Diabetes Federation's recommendation to keep post-meal glucose elevations under 140. I also think that there is a real possibility and opportunity for the inclusion of continuous glucose monitoring into a physician's workflow for helping patients with diet and lifestyle. And I think this could be a really positive addition for many practices and physicians. Many of us are, bandwidth constrained in terms of doing the on-the-ground, day-to-day coaching of nutrition. And many individuals are trying very hard to lose weight and optimize their diet and aren't necessarily seeing the results that they want. Research from published on the CDC website suggests that each year, about 49% of Americans try to lose weight. And as we know, as a population, we're getting, our weight is going up. We're getting more overweight, more sick, more depressed as the years go on. So having a tool that gives people really like a handhold and really grounds people into objective data about what their dietary interventions are doing to them could potentially really shift the relationship between the doctor and patient, where the advice is not just coming from a personal recommendation from the doctor, but really that the patient is producing their own data that's helping to guide their diet. And in addition, this can help physicians really kind of with that coaching element of diet by giving the patient a tool that essentially gives them real-time biofeedback and sort of this digital coaching day to day at home as they're making those, dozens of micro decisions each day that ultimately generate health. So that is the end of my talk. Thank you so much for your interest in this topic and for listening. And please feel free to let me know if you have any questions and reach out to me by email. Thanks so much.